And go ahead to the next slide.
There's our disclosure.
And the next one. To CT or not to CT? That is the question. Whether 'tis nobler in the mind to suffer the slings and arrows of medical staff QA and press gainy complaints from parents, or to take arms against a sea of standard practices, if not standard of practice, and by opposing, end them. To say we end the heartache and the 1,000 natural shocks that these decisions are heir to. 'Tis a consummation devoutly to be wished. To decide and then to go off shift to sleep perchance to dream. Aye, there's the rub. So with extreme apologies to Shakespeare, we have a hard job. You know, we see adults, we see kids, we see people at one instance in time and have to make decisions that may impact their entire lives. Today, we're going to talk about head injuries in kids. Really, my objectives are pretty straightforward. One, we are talking about kids with Glasgow Coma scales of 14 and 15. We are not talking about those kids who are obviously messed up, obtunded, that you're already intubating. That isn't what we're talking about today. We're going to talk about these iffy kids, okay? My biggest take-home point is that there are some really terrific clinical decision rules that help us make a decision so we can go home and go to sleep. And ultimately, what all of these decision rules really have found is that for the kids with a Glasgow Coma scale of 14 or 15, less than 1% is going to ever actually have a clinically important traumatic brain injury. And in terms of actually requiring a neurosurgical intervention, we're really talking about somewhere between 0.1 to 0.6 of all kids who have injuries that will actually, of these kids that are 14 or 15 Glasgow Coma scales, that will require a neurosurgical intervention. So my goal is kind of making people a little bit more comfortable with the, oh, do I really need to do a CT in this situation? We're going to touch on a little bit about the concept of traumatic brain injury versus concussion. And then what I really want you to be thinking about in the back of your mind for those of you who are in more community settings are, is this a kid that I can observe? And if I observe them, how long do I observe them? And what the heck am I observing them for? Next slide. You know, it doesn't matter where we practice. These kids sneak into our EDs all the time and into our clinics, you know, and when they show up, whether it's from a dramatic injury of a, you know, a rollover car accident, and now you've got a teenager who's acting kind of concussed, but is otherwise talking to you and looking good. You have that drama, to the drama of the parents looking at their, you know, 2-year-old who's absolutely fine, but they're insisting needs a head CT right now. So I'm a big believer in trying to keep my ED as free from drama and whining as possible. I'm also not a big believer in secondary gainers. So, you know, parents aren't allowed to kind of direct that, but we can have shared decision-making together. Next slide. So why am I talking to you about this and why should we really care? There, you know, from the best data that we have, this is back now 2014, you know, close to 1 million kids under, you know, 17 or under present to an ER or a clinic for concussion or TBI. Over the span of 8 years from 2006 to 2014, age-adjusted visits for TBI actually increased 54%, while hospitalization rates actually decreased. What's interesting about those age-adjusted patterns is during that time, it's actually the very young and the very old who had the biggest increases. It's kind of a U-shaped curve. And so we think that part of that really has to do that between 2006 and 2014, we've really done a lot of education in terms of our kids wearing helmets when they ride their bikes, our soccer players not doing so many headers. But a lot of that education was directed towards those active kids in sports as opposed to young children who still fall and toddle and bump their heads, and the older crew. It's also important to remember that 1 in 4 kids who have a traumatic brain injury visit to an ED, that 1 in 4 of those are caused by being struck by or against an object. And remember that unintentional injury remains the leading cause of death for children ages 0 to 4. And because part of my job is also child abuse pediatrics, I also have to point out that between 0 and 4, homicide is the number 4 cause of death in kids. And between ages of 4 and 25, homicide remains usually number 3 in the US as causes of death. Next slide, please. So again, we've seen not just the age-related increase, but an actual 8-fold increase in TBI visits to EDs and to clinics. And most of those visits do not go to trauma centers. More than 1/3 of the visits are children, and less than 2% of those kids are being seen in pediatric specific EDs. So to me, this really underscores the importance of our kind of child-ready network here in New Mexico, where we as PEDS docs like to think of ourselves as, oh, we're the ones who take care of the kids with the injuries. No, we're not the ones. It's everybody out in the community, everybody who's joining this talk. You're the ones who are taking care of the majority of these kids. Next slide. So the other reason, why do we care? Well, there's this little thing that happened in the early 1940s where we dropped bombs on Japan, and we kind of found out that radiation was really, really bad and dangerous. Well, guess what? Even CT scans and x-rays are kind of dangerous. We kind of off the cuff will make comments. I know one of the things that I use all the time with families when they're worried about a chest x-ray is, pre-COVID, I used to say, oh, well, a chest x-ray is about the same amount of radiation you get flying from San Francisco to New York. It's about the same exposure, not a big deal, something that we deal with. But CT is a whole different ballgame, and CT in children in particular are a whole bit different ballgame. What we really worry about is not just this one-time event of a child getting a CT, but over a child's lifetime, how many CTs are they going to get, and how additive is that? So, again, just looking back at just head CTs, the risk of leukemia for kids under the age of five years of age with one head CT is 1.9 cases per 10,000. That's a big deal, And then we kind of have to take that step back and think about CT and the studies that we do and distinguish between what's the individual risk today at this moment and what's the collective public health risk. The individual risk here for this particular kid is really small from getting a CT. And the benefit about finding out that they have some horrible, bleed in their head that needs to go to the OR, hey, well, that's going to be a big benefit. But now you take the fact that there are 2.7 million kids getting head CTs and you multiply that times the number of kids who are going to be affected by that. And now we've got a group of kids who are going to have, there are going to be 5 to 10 kids who are going to have a new leukemia because of what we did 5 years ago, 10 years ago. That's pretty scary. So as always, I talk about how challenging our work is. We have this problem of trying to decide there's a risk about missing something, but there's a risk of causing problems later, and we have to be prepared for those. So kind of with that as a background, I want to speak a little bit to the clinical decision-makings possibilities that we can use to make these decisions a little bit simpler for the practitioner. Next slide, please. Years ago, I was working at the University of Michigan, and at that ED, the peds ED docs stopped at 2 a.m. or 1 a.m., something like that. And from midnight until the next morning, there was one pediatric resident who would present patients to the general EM attendings in the ED overnight. And they didn't have as close of a relationship with the EM docs, and they were always a little upset about it. And I remember I was getting ready to leave, and one of the third-year peds residents said, "Hey, Jeff, can I just ask you one quick question before you leave? There's this kid, he's 16 years old. He had a VP shunt when he was a baby. He's only had one revision when he was 1 year old. He also has a history of migraine. He's here for a migraine. He saw his neurosurgeon yesterday and had a CT and told that everything was perfect. And he's here with a migraine. You always say to image any kid who has hardware in their head. Do I have to image this kid, or should I just go ahead and get treat his migraine?" I said, "Well, why don't you treat his migraine, see if he improves. And if he doesn't improve, then go ahead and image his head." I left. The next morning, the kid wasn't there. I was happy. About 2 in the afternoon, I get a call from EMS. They're bringing in a 15-year-old obtunded child. And I'm like, oh, shoot. And I knew it was this kid. And sure enough, it's this kid. And he's got major hydrocephalus from his CT, immediately gets intubated. And when I went home and told my wife that story, who was doing her anesthesia residency, it kind of gave birth to her parting words to me every day I go to work, which are, "Just get the CT, Jeff." It's a hard thing to decide about doing these. In an ED setting, sometimes just getting the CT, hey, it's quick, it's easy. I can make my disposition. I can convince the family that this kid is fine. I don't have to keep them around in my busy, crowded ED for hours and hours reevaluating. I'm done. By the same token, if I don't order a CT, is that safe to do, not ordering a CT? Now I'm going to keep my kid in the ED even longer. Now I'm going to admit them or, have a risk of admission. And keeping a patient in the hospital, that has its own risks. And so if you look at countries like Australia and New Zealand, they have a much lower CT rate for these kids than we do here in the States. But they admit way more of their kids. And so again, there's always this, what works for this child at this moment, and that's where the decision-making rules are helpful. So next slide, please. So there are 3 clinical prediction rules that all came out about the same time, somewhere late 2000 aughts to 2009, something like that. Chalice came out of the UK. It's a prospective study. It looked at 22,000 kids. The clinical outcomes it looked for was what they called significant TBI, and they considered a significant brain injury to be death, requiring neurosurgery, or marked CT abnormalities. The PCARN study, which is what we're really going to talk about today, is the huge Pediatric Emergency Care Applied Research Network study, 42,000 kids. they looked at very similar clinical outcomes. And then the Canadian study, CATCH, which also was a little bit smaller, but also looked at the same severe outcomes. What's really important to know, though, is that Chalice and CATCH are slightly different setups than PCARN. Chalice and CATCH are designed to tell you, when should I do a CT? PCARN is kind of designed to tell us, when is it safe to not do a CT? Next slide, please. So, not to go into the weeds too much, but PCARN looked at, there were 25 pediatric sites throughout the US. They had this huge group of prospective patients enrolled. Half of them were made into what they called a derivation group and half into a validation group. They excluded trivial mechanisms. So your toddler running in the house who falls down and goes boom is not included. They only included pretty significant mechanisms. Falls, if you're under 2 years old, falls of greater than 2 feet. If you're greater than 2 years old, falls greater than 5 feet. Car accidents, bike accidents, they're really good, gory, potentially bad injuries, okay? But they also did limit it to the kids with Glasgow Coma scales of 14 and 15. They did very standardized assessment, case report forms. They took all this data, churned out all this information, and kind of came down to, next slide. Next slide, please. Oh, wait, go back one. There we go. They ended up defining what they called clinically important traumatic brain injury. And to be clinically important, these were the big outcomes they looked at, were death from a traumatic brain injury. Yeah, that's kind of clinically important. Neurosurgical intervention for the injury. Children who had a traumatic brain injury and required intubation of more than 24 hours. Children with a traumatic brain injury found on CT that had to be hospitalized for more than 2 days, okay? They defined those kids who were hospitalized for more than 2 days with traumatic brain injury as the kids who either had, persistent altered level of consciousness, recurrent emesis, severe headache, or ongoing seizure management. And kind of what I want to point out is, other than the ongoing seizure management, those other 3 things, mental status, recurrent emesis, and persistent severe headache, those are pretty standard fare concussion issues, right? So is it a concussion or is it a traumatic brain injury that's more significant? That's an area of PCARN that's difficult to define. Next slide, please. These are the things that were found as traumatic brain injuries on CT that they considered. So pretty significant injuries. Was there hemorrhage? Was there cerebral edema? Was there an infarction? Was there pneumocephalus? So you really had to have a significant finding to be considered in this group of kids who were hospitalized for 2 days and had a traumatic brain injury seen on CT. Next slide, please. I don't want to go into the weeds too much, but just to give you an idea of kind of the power of this study, they started out with about 55,000 kids, ended up getting down to the 42,412 kids with GCS of 14 to 15. Those kids they divided into greater than 2 years of age and 2 years and younger age. And then they divided each of those groups into what they called a validation group and the derivation group. The derivation group kids were the ones that we used. Okay, what things did we find that actually made a difference in making our decision as to, can we safely not get a CT? Next slide, please. So I show this again because of the concussion issue. One is kids can act pretty goofy, you know, and kids with a brain injury and kids with a concussion, which is a brain injury, can act goofy. And guess what? If you look at that top line in red, if you look at the kids who were acting abnormally according to their parents, and then you look at the bottom line in red, the bottom two lines in red, that show kids with altered mental status. So those are kids that we as the providers decided were altered. Those percentages between parents saying their kid acted abnormally and we agreeing that they acted abnormally, they're fairly close, a lot closer than I expected, okay? So yes, parents are pretty good judges of telling you that their kids are acting unusually, and I think that's incredibly important for the kids 2 years of age and younger. You know, remember, the younger you are, the tougher it is to hang your hat on your neurologic exam. As Dr. Leslie Strickler, the head of our child abuse group, says, when it comes to kids under 6 months, don't trust anybody's neuro exam, not even your own. Remember, a kid under, 2 or 3 months, what do they really do? They eat, they poop, maybe they try to roll a little bit, maybe they make good eye contact and smile at you, but there's not a whole lot. They're not doing calculus in front of you. Now, I know, Sarah Dakin's puppies all are brilliant dogs, and I know all of your children are brilliant, but you know what? It's tough to figure out if kids have a normal neuro exam when they're infants. So if a parent says they just seem funny, yeah, you kind of got to trust that. Next slide, please. The other portion that I want to just touch on is one of the areas that they found were really important were scalp hematomas. And I'll be honest, that kind of surprised me because let's face it, all kids, especially the toddlers, they lead with their head. They all, are born with these ginormous heads and they only get bigger the first 2 years of their life. So whenever they fall, they land face first and they get these big noogies in the middle of their forehead. I had always kind of been trained and always had really believed, these big hematomas in the middle of the forehead or on the back of the skull really aren't a big deal. The ones that we worry about are the parietal and temporal ones because that's closer to the middle meningeal artery, and those are the ones to worry about. If we go to next slide, please. Really, P. Karn kind of says, occipital and temporal parietal are all just as bad and are one of the things that really we should be looking for. So again, I have to digress. So, years ago when my now 30-year-old son was about, 2 years old, he and I were home together. He was playing around watching TV. I was folding laundry on our, we had a picnic table as our kitchen table at that time. And I was folding laundry. I finished folding and I look and he's fallen asleep. So I'm like, awesome, I'm gonna run and put all this clothes away. I run upstairs, I get upstairs and I hear bam, scream. I go flying down the steps, find Craig lying face down under the picnic table. I'm like, Craig, what happened? He's like, climbed on table, fall, ow. I pick him up. He's got this little bump on his forehead, no big deal. We run around. We have a great rest of the day. It's now, this happens at about 11 in the morning. It's now about 5:36 and he takes a nap a little bit later. He's laying down on the couch. My wife comes in from work, picks him up, and he now has, and I'm so glad Robin Blumberg is on because he now has not a 4-head, people, he's got a 5-head. He's got this huge knot in the middle of his head. And she's like, what did you do to my baby? And, luckily our pediatrician also happened to be a PEDS-EM doc at that time. And so in the middle of the evening, we rushed Craig out to be seen by his pediatrician. And of course, he was completely fine. Now, if we had only had P. Karn, I might have been able to convince Deb that, no, we didn't have to rush out in the middle of the night. Next slide, please. But here is the meat of what I told you at the beginning that I wanted to talk to. So we got these thousands of kids who all had non-trivial mechanisms of injury. And the kids who were defined and found to have these clinically important traumatic brain injuries, so the kids who either died, who needed surgery, who had to be intubated, who had to stay in the hospital, look at those percentages. It's about 1%. And of those kids, if we do the next slide, in the PCARN study, we get down to that 60 kids out of the 42,412 who actually required neurosurgical intervention. So 0.14%. So I bring this up to say that even if you convince yourself that you need to do a CT, there's a really low risk that you're going to have to do anything about what you find on that CT in kids with a Glasgow Coma scale of 14 and 15. All bets are off on the kids who are 13 and lower. Of course, you're going to be CTing those kids, and those kids are probably going to need some interventions. But for these kids who were in severe mechanisms, but clinically are with it, really you can kind of relax in terms of how often do I really need to get these CTs. Next slide, please. So PCARN looked at about 35 different variables, and this is what it boiled down to. For the kids who were 2 years old and less, the first questions you ask are, do they have a Glasgow Coma scale of 14 or 15? Are they altered, or do they have a palpable skull fracture? If the answer is yes, PCARN says they've got a 4.4% risk of clinically important TBI, and you should consider getting the CT. Okay? After what I just told you, even in this group, there's still going to be a pretty tiny risk that you're going to miss something that's going to require a neurosurgical intervention. And I would suggest that those children are a little more clear-cut to you. But this is how PCARN defines it. And I think this is a good, safe group. 4.4 risk, that's a pretty big risk. If you answer no to that, you say, oh, do they have a big hematoma in the occipital, parietal, or temporal region? Was there loss of consciousness for 5 seconds? Was there a severe mechanism? And then you define this group of about a third of the kids who are at this 0.9% risk of CTI. And do we observe them, or do we go ahead and do the CT? And that's where kind of the decision-making really comes in for you as the practitioner. And then the other kids we can skip. Next slide, please. For the kids older than 14, or older than 12, we go through this pattern. And in our case studies, we're going to bring up the MedCalc PCARN studies that you can use. It's the tool that's on MedCalc. And that way you just plug in these quick questions, yes and no, and help make you a decision as to what you really need to do. Next slide, please. So hopefully with PCARN, your decision-making is a little bit better than my squirrel friend here. I do suggest that what you have to think about are which kids are goofy, the kids with a concussion who clearly are awake and alert, but are repetitive. Those are the kids that are tough to decide about, because by PCARN criteria, they have altered mental status, and that might be a group of kids that you want to get your CT rather than observing. I would suggest that a lot of those kids really can be observed. Then you have to really decide how long is a long enough observation, and nobody has an answer for that. I personally tend to use 4 hours, but that's really up to each practitioner. And I think it's variable depending on your family that you're dealing with. And this is where shared decision-making really comes in. Next slide, please. So obviously a pre-COVID photo of my granddaughters and I. When I consider my situations with my patients who have a good Glasgow Coma scale, I think if they don't have a sign of a skull fracture, if they don't have focal neuro signs, if they're returning to baseline, those are kids I'm not going to be getting a CT on. I do a lot of observation. I said 4 hours, but I cheat sometimes. Oh, you didn't come in until an hour or two after the injury. I'll keep you in my ED for another 2 hours maybe and see how you're doing. I engage the parents because that's what it's really going to take, is that comfort level, not just for you as the provider, but also for the family. Don't forget about the diagnosis of concussion and close follow-up. Also, just to throw it out for those in the ED, I personally never clear somebody from the ED for participation in sports again after a concussion. I make them have a follow-up visit with their doc. I just think you're set up for all sorts of issues if you do it. I think that's the last slide. A quick shout out, and I'm sorry for going too long, Danny, but please check the chat and remember to look at the links for sign in as well as for the CME credit links. Anything else that I missed, Catherine? All right, so why don't we have Danny move into the cases. Danny Mascarenas is one of our senior pediatric emergency medicine fellows. She will be doing some work at UNM when she finishes, but also her main job will be in Spokane, Washington. Thanks, Danny.
No problem. Thank you so much. We'll take a second to get the next slides up. Thank you.
You're welcome.
So we're going to go through a few cases. If you're like me, it's hard to know what to do unless you start to apply the stuff that you've learned. And so I do think that going through cases together is really helpful. We can ask questions during the cases, or you guys can wait till after or talk about some cases that you've had too. Go ahead and hit the next slide, please. So we'll start with the first case. This one we titled A Great Concert. So this is a 17-year-old who presents with headache, dizziness, and nausea 16 hours after attending a community concert. She was standing up dancing in the front of her seat. A fight broke out behind her and she was struck by a glass bottle on the left occipital parietal region. She stumbled, fell forward, and was caught by her friends and lowered to the chair. Loss of consciousness was about 5 seconds. She has no cuts, no bleeding. There was no shaking, tremors, or seizure reported by her friends, no vision changes, and she had an immediate headache. She did complain of neck pain, lightheadedness, nausea, but no vomiting. Next slide, please. So she was doing okay. I guess the concert was really great. She remained for the end of the show. She slept okay that night. She went to work this morning, the day that she presented, but her headache and neck pain and nausea all persisted, still with no vomiting. Her supervisor at work told her to go to the hospital. She complained that it was worse when she turned her head. Next slide, please. So we got a little bit more information. Her review of systems at this point, besides the nausea, were non-contributory. She has a history of depression, allergic rhinitis. She works in admin. She lives with her parents and she has an intact family. She denies any use of alcohol or drugs. Next slide. She does have a set of vitals that are within normal limits. So her temp is normal, 36.8, heart rate 72, respiratory rate of 18 with a blood pressure of 112/75. She's 67 kilos. So for her neuro exam, which is really important for us as we're considering head injury, we noticed that her cranial nerves were intact, her reflexes were normal, she had normal tone, strength, sensation, and coordination. She did have a tender left posterior insertion of the SCM to the SCM muscle to the skull, but her memory was intact, she had no confusion, and she was not repetitive. Her GCS at this point is overall normal at 15. Her HENT exam was normal. Her cardiovascular exam was also normal, equal pulses, regular rate and rhythm. Respiratory was also normal, so she's cleared auscultation bilaterally. Her abdomen was soft, non-tender, no masses. This is really important to go ahead and examine as well, especially when we're seeing a lot of kids that might have viral gastro, or we're thinking about just the nausea piece. But it was normal for her. And then as far as her extremity exam, she had full range of motion of all extremities. Next slide. So what other questions? Can you guys think of any other questions that you would have asked, or any other physical exam points that would have been helpful for you in making the decision of should we CT or not CT this patient? And I can't read the chat if anybody wanted to look at the chat.
No other questions, Danny.
All right. So a couple of things I would have considered, because we did do a normal physical exam, but I would have asked about weakness, numbness, or tingling. If she was there with somebody who knows her well, and we talked about this particularly for little kids, but have there been any behavioral changes, so repetitive questions, things like that. Looks like Jane, sorry, I can't see the chat after all.
There's a question about any pupil exam.
Perfect. And that is something that we should have documented here in our physical exam. But are the pupils equal and responsive? Do we have one pupil that's more dilated than the other, not as responsive as the other? That would indicate that we have a serious head injury or something else is going on.
They were equal.
Perfect. Thanks, Jeff. So in the end, completely normal physical exam. So next slide, please. So we decided to plug her in because it's not totally consistent, or excuse me, totally obvious if we should do a head CT at this point. I think she looks like she sounds great. She's had some complaints, but she still has headache and she still has nausea. And we have this history of loss of consciousness and a pretty good mechanism of injury. So we can find PCARN, as we mentioned earlier, on MD Calc. Super easy to find. You simply just put it in Google and you say MD Calc PCARN and your algorithm will show up, and you can actually just click on everything and plug things in, which is awesome. So if you go to the next slide, we plug her in. So she's greater than 2 years of age. Her GCS is normal. So we say no for GCS less than 14 or signs of basilar skull fracture or signs of altered mental status. And next slide. But she does have this history of loss of consciousness and a history of nausea, but no vomiting. So we say yes to that answer, and still we come up with a 0.9 risk of clinically important traumatic brain injury. So for her, even though she's had this history that is concerning, even though she's had this history of loss of consciousness, and on her presentation, she still has some symptoms, her risk of having a significantly important traumatic brain injury is pretty low. So next slide, please. We do not do the CT. We do send her home, and then we hope that she chooses better venues for music in the future. This patient did not come back, at least within the next 24 hours. So at this point, we made the right decision. But we always send patients home with information about close return precautions, following up with their PCP, because again, she might have this history of nausea and headache, symptoms of concussion.
And just to point out, if we had seen this kid the night she got whacked by the bottle, she would have still been at 0.9%, but we wouldn't have had 12 or 16 hours post the injury of observation to know that she was fine. And so it might have been okay to do the CT that first night, but the next day, the kid's pretty much fine other than a headache. No, I don't think it's worth the risk of the radiation.
What type of return precautions did you give them?
It's a good question. So really when I want to see them again is I say it's hard for families to remember all the things that you tell them. So thankfully we have handouts for vomiting or head injury or concussion through the pediatric emergency department. But we do say that if there's any changes different from what they're presenting with today. So if they have starting to have vomiting, worsening nausea, worsening headache, they're now having symptoms of numbness, tingling, weakness, Families noticing that they're maybe a little bit more altered. Stuff like this can still be considered concussion, but I think it's better that the family doesn't decide if they need to do anything further. It's better if we help them decide that, and if we need to do a CT, or if we just see them again and say, hey, this might still be concussive symptoms.
Thank you.
All right, yeah. Let's go to the next case. So we have a second case coming up. So this one is fall from chair. So 3 of these cases, just so you know, are cases we saw in one day in the emergency department. So we do see head injuries quite a bit. So this is a 16-month-old who was climbing on a folding chair and fell, striking his head on the corner of a metal bed frame. This happened 3 days ago prior to his presentation today. He had no loss of consciousness at the time of the injury. He cried immediately, but returned to his baseline after 5 minutes. He does have a bump to the right side of his forehead. He was fine post-injury day 1 and 2, but on day 3 had 12 episodes of vomiting lasting about 8 hours. All of his episodes of vomiting showed that the emesis was non-bloody and non-bilious. However, mom is concerned that he's not acting right. He's more subdued and seems unsteady on his feet, but he's had no fever, no diarrhea, no rash, no other symptoms, including cough or congestion, and no one else at home is sick. He didn't attend daycare either. Next slide, please. So at this point, review of systems are otherwise non-contributory aside from what we had mentioned. Past medical history, he has no significant past medical history. He's up to date on his vaccines. He's not on any meds, no allergies, no hospitalizations or surgeries. As far as family history and social history, also non-contributory, lives with his parents in Albuquerque. They have all the amenities. So thinking about, do they live on one of our Native American reservations where they have maybe less access to electricity or water? And then something that's good to ask, I don't always ask all families, but particularly with kids that are a little bit younger, are there any weapons in the home? And this family denied weapons in the home. Next slide, please. So on his physical exam, his vitals were also within normal limits. So normal temp, heart rate, respiratory rate. We did not get a blood pressure on this child to start, but certainly we could ask for one if he looked like he was sick. So he was quiet, alert, he was interactive, he was using all extremities. He did have some ecchymosis and a hematoma with some linear abrasions from the bed frame on the right side of his forehead. He had no subconjunctival, hemorrhage. His TMs were normal. His neuro exam was also normal. So his balance seemed fine for us. I know mom had that complaint that he seemed off balance, but he had a normal toddler gait and his GCS was 15. Besides the ecchymosis and the hematoma, his skin was otherwise without any lesions. He had most mucous membranes, rapid cap refill, and his abdomen is soft and non-tender. So overall, patient looked really well. He just had these physical exam findings on his forehead. Next slide, please. So we're back to the question, to CT or not to CT. A couple of questions and things to think about that you may have caught when Jeff was talking, but is PCARN applicable after 24 hours? This kid has already been outside of his injury about 3 days and he looked pretty good otherwise. So do you guys have any thoughts about, can you still use PCARN for this case? And it's okay if you don't know. So for him, what we did do is, next slide, please. We did apply PCARN for him to see where he plotted out. So he was less than 2. And we did put in there that he had altered mental status. So he had some, he was just not acting quite right per mom. That was kind of what she had said. And then had these episodes of vomiting and just seemed kind of blah overall. So we put yes for that. Next slide, please. And then we realized that PCARN wasn't as helpful for his case. I think in some cases for our little guys, we can use PCARN retroactively. So if we had a history that maybe he's coming in on day 3, but we're like, oh, something was interesting about his history where he was a little unstable on his feet, which mom said started on day 2. So was that within the 24 hours? Was that right outside the 24 hours? Hard to say. His vomiting didn't start until day 3. He's less than 2 years of age, which is something to just think about because he's a little bit younger. It's harder to really know what his neuro exam would be. And so for him, in the end, we ended up getting a head CT because the story just didn't quite make sense to us. It could be something that's a virus that's starting to brew, but without fever, sick contacts, no other symptoms, but then had this recent fall. For us, it was better to just go ahead and get that CT.
I just want to break in for a second, Danny, because I
Yeah.
went so long. We're getting close to 9 o'clock. I want to be respectful to other people's time. We do have 2 other brief cases that we'll zip through. If you would like to stay on, great. Again, we understand if you need to log off. Thanks.
And Dr. Kurland had a question. His symptoms could have started when his bleed expanded beyond minimal size.
Perfect. And that's what we had thought too. And that's what changed, or I guess prompted our clinical decision making, is that without the other symptoms or fever or anything else going on, and he wasn't, quote, acting right, and he had the vomiting, we decided that this was the guy that maybe he did have a pretty significant head injury at the time of injury. What, I don't know, we didn't see him right after within the 24 hours. So would we have gotten a CT that day? Maybe not if he looked pretty good. But now that he has symptoms that have worsened, so this is somebody who's good return precautions, came back because things were not quite right. Could this have been a bleed that expanded? And the answer is yes. And that's why we got the CT in the end.
Right. So this is a situation where we used P-cardin criteria, but P-cardin criteria really isn't set up to be used in kids after 24 hours. That's just the original design of the study. Nobody really knows if that information is valuable after the fact, but I feel like as a practitioner, it gives me something to kind of help decide afterwards. And again, with this kid, because there was such a change afterwards and he had evidence of a good hematoma on his head, I think it was a reasonable thing to do.
All right. So our next case, fall and fever. So we have a 4-year-old who was jumping on the bed last night at 23:30. He fell off and she fell off and bumped her head. Mom says the fall was about 4 feet. There was no loss of consciousness, no bleeding. She did complain of pain, but after we iced it, she felt better, no nausea, no vomiting, no seizure. She slept until about 5:30 and then she felt hot. Mom took her temperature and it was 103.6 and she was given ibuprofen. She slept a few more hours and awoke with headache and neck pain. The fever recurred approximately 5 hours after ibuprofen. Mom endorses now that she's less talkative than normal, but she still had no vomiting, no diarrhea, no URI, and no COVID exposures. Next slide, please. So on review of systems, she had headache, but she was not altered. No dysuria, no urgency, no diarrhea or constipation like we mentioned, and no URI symptoms. Past medical history, so she's 4 now, but she did have GBS sepsis at birth. Her heart murmur was noted at birth, but had a normal echo. She's had no other hospitalization, surgeries, not on any meds, and vaccines are up to date. Her family history and social history, intact family, so non-contributory overall. Next slide, please. So in terms of her physical exam, so she's not febrile now, she's 37.3, heart rate's 120, respiratory rate's 20, and blood pressure is 107/99. So she's not looking like a child who is septic. As far as head injury, so she's active, alert, she's playful and engaging. Her neuro exam is normal, so she's normal balance, strength, sensation, normal reflexes. For HENT, her TMs are normal, pharynx is normal. She's breathing well without any work of breathing, and her abdomen's soft and non-tender with no rashes. So overall, looks like a kid that's looking pretty good. She's just not quite at her normal baseline. Next slide, please. So here we are again, to CT or not to CT, and a few additional questions when we think about fever and head injury. So the first, does a head injury cause fever? Does a fever cause behavioral changes? And can you have a concussion and fever? So I'll talk about the first one, and I think these are all really great questions. I think the first one, I would say overall, head injury does not cause fever when the child is overall well appearing. if you have a child that has multiple symptoms and they look like they are somebody with a significant head injury, we can go further along about autonomic nervous system, neurogenic fever, things like that. But that is a sick kid who's been sick for a while, and it wouldn't necessarily apply to this child in this case because the kid looks great otherwise. So I would say for this child and this question, does a head injury cause fever? No. Does a fever cause behavioral changes? The answer is yes. So kids can be really fussy, really irritable, agitated. And is it the fever that's causing it? Or is it more like the underlying illness? So maybe they just kind of have muscle aches, they feel kind of crummy, and they can look like they feel crummy and they can act like they feel crummy, and they are allowed to do that. And so when we give ibuprofen or Tylenol, a lot of kids can have a totally 180 turnaround change because the fever has now resolved, but maybe some of those other symptoms that they can't really express have resolved as well. And then can you have a concussion and fever? So yes, you can certainly have both. The kids get URIs all the time. They get viral infections regularly, especially if they're in daycare at school or at school. And they bonk their heads pretty regularly too. So it's pretty easy for them to have a URI that's brewing or something that's brewing, but then they're also dealing with concussive symptoms from a recent head injury. And then now we have fever, but maybe we had some vomiting, but we also have cough and congestion, and it's kind of mixed all together, but they can certainly have both. Jeff, did you want to comment on anything here?
No, I mean, I think this is just, the challenge of, are things true and related, or true and unrelated? I really don't think it is rare for a head injury by itself to cause fever, period, no matter how much the family wants to associate that. And that's part of your job, is saying, nah, not really what's going on here.
All right, next slide, please. So with the child's temperature controlled, mom feels she's more herself, so she's getting back to her baseline. They're unable to provide a urine sample, which in this case I would totally recommend doing, but mom doesn't want to do the cath, and so that's okay. And she also refused COVID-19 testing. So in the end, we did no CT. She was discharged home. And this patient, overall, with her looking well and with this history, I don't know if I have, let me see, can you go to the next slide? PCARN here. But basically, if we had plugged her in, it would have been low risk. And at this point, we wouldn't have done the CT, both on clinical decision-making, but we used the tool and it would have said no CT. So case 4, we have a 1-month-old who slipped out of the car seat and fell to the concrete. The infant was strapped into the car seat and was also bundled in multiple blankets. Dad removed the car seat and infant from the car, grabbed the seat by the handle, and then the child slipped out, landing on the concrete and hit the back of his head and back. Baby cried. EMS was called and evaluated the patient. However, parents refused transfer to the ED, but agreed to go see a physician the next morning. The accident occurred in a homeless shelter parking lot, and this was captured on their video as well. Next slide, please. So the next morning, the PCP did see the patient. Overall, the baby was well appearing. There were no lumps or bumps noted. The patient was treated for thrush and then DC from the clinic. The shelter personnel reviewed the video, and they were still concerned about what the video looked like, so they contacted CYFD. CYFD referred that the child go to the ED. This is now 3 days after the accident for evaluation, as the impact of the fall looked pretty great and serious. Next slide, please. So as above, parents didn't have any significant complaints. It sounded like there were no major changes for the patient's clinical course now 3 days out. Review of systems were overall non-contributory. Past medical history, mom on buprenorphine during her pregnancy, but otherwise pregnancy was uncomplicated as well as delivery was uncomplicated. Family history and social history, so does live with both parents and they all live in the shelter. On physical exam, patient has an atraumatic head, normal cephalic, the anterior fontanelle is open and soft, no lumps, bumps, or step-offs palpated. For neuro, the neuro exam is grossly intact, and then there were no other significant findings, including skin findings, work of breathing, normal cardiac exam, and normal pulses. Next slide, please. So again, to CT or not to CT. So this case is a little difficult for the PCARN algorithm at this point because of a couple of reasons. The first being that the child is 3 days outside of the injury. That kind of makes it a PCARN excluder, and it's just not as useful unless there were maybe symptoms within the first 24 hours and you apply it retroactively. Secondly, at this point, we're also concerned about some suspicious stuff that happened in the parking lot. It was even caught on video, and there was concerning findings that were witnessed. And so at this point, we're thinking, is this non-accidental trauma? And non-accidental trauma is a PCARN excluder. And so we do not use PCARN for any case that we think might be a head injury related to NAT or some sort of physical abuse at this point.
And it wasn't that the video showed anything different than what the parents had described. The kid literally just slipped out. But what really impressed the people at the shelter was just how hard this kid hit the ground and her head bounced off the concrete. That's why they got nervous. And rather, you know, and then I think because it was in the shelter's parking lot, they felt responsible. And that's why CYFD got involved. And when all those things happen, and then you go, oh, homeless shelter, mom was, you know, an opioid addict, and now she's in recovery. As providers, we start to kind of bump that up into that NAT situation. Whether it really is or not, doesn't really matter. It sounds like ultimately the video actually shows clearly that it was an accident. But yeah, what do you do with this kid?
Next slide, please. So we got the CT. So in this case, we are concerned, maybe not about NAT, but concerned enough to where we probably should do something a little bit more than just look at the patient and discharge back to the shelter. So this patient did show to have a skull fracture, and thankfully we have an arrow there. It looks like in the parietal region. And as you can see in the same plane, if we look to the other side, we do not have that same defect in the skull as well. So that's a good indicator. And then it looks like obvious swelling or tissue swelling also. Next slide, please. And again, here's the skull fracture, 3.3 millimeters is noticed here of how much of a bleed we have underneath the skull there where the fracture is located. So to reiterate, the patient looked fine. The history was a little funky. We had some NAT, or excuse me, some CYFD involvement. So at this point, this patient, like we said, did not fall into the PCARN categories. And it sounded like within the 24 hours after the patient had the incident, was seen by a provider and also looked really good. So I would not necessarily fault the provider or I wouldn't fault the provider for not doing a head CT at that point. It was when we were concerned, CYFD got involved. And at this point, we were like, well, we should probably do something more to look into this further. But patient overall looked okay. So
the other thing that I think is always important to know with these parietal skull fractures like this, often you don't have a significant overlying hematoma for up to a week afterwards. And so I totally believe that the doc who saw this kid the first day didn't feel any lumps or bumps. We didn't feel any lumps or bumps. Even on CT, yeah, there's a little bit of swelling, but not very much. So it's really tough to tell from the outside. Kind of goes back to the younger a kid is, don't trust your neuro exam. I'm a little quicker on the draw for doing the CTs. Plus, when I put my child abuse hat on, this was a kid that ended up getting CT and a skeletal survey. Skeletal survey was completely normal and nothing, you know, CYFD closed the case immediately. And I believe that.
I think that's it. So conclusions, which we've kind of tried to talk about a little bit here and there, but of course, PCARN is a great clinical prediction tool for serious TBI in kids, at least excluding them and when not to get a CT is kind of how the wording goes as far as when you look up PCARN information. But you can easily find the algorithm on MD Calc. We use it all the time in the PDD. I bring it up pretty regularly. And it does not work for every child. So again, to reiterate that, use it when you can within 24 hours of the head injury, but also think about Is there something weird about the story? Is there something else to the story? We're a few days out and stuff is still going on. Of course, if there's concern for NAT, you might want to just go ahead and get the CT in that case too.
Yeah.
Kind of as Jeff's
Danny,
wife would tell us.
Dr. Curlin has some comments in the chat, just saying, you know, one, you got to use the decision rules in the right situation. And I think that's incredibly important. And again, kind of commenting on the beginning of what we talked about, that careful balance between not radiating kids, but not missing something really bad and scary. So couldn't agree more with you, Jason. I think all of these decisions really do have long-term impact. And I think it takes a tremendous amount of experience and a tremendous amount of rapport with the family to make a decision that everybody can live with.
I agree. Thank you so much, Jason, for making those comments too. Because I will say too, even in a place where we see head injury frequently, and as a fellow, there's a lot of kids who don't fall into the category of just using an algorithm very easily. And so we do thankfully have a couple of different docs to bounce the discussion of should we get a head CT versus not with each other. And of course, I always reiterate is that if you have questions or concerns, you can always give us a call too in the PDD, and you have other docs to talk to maybe help you make that decision, or if we're concerned about the kid, to transfer over. So definitely lots of collaboration here because not everyone follows into the correct categories all the time.
And with that, I really want to thank everybody for sticking with us. I apologize for going over. Luckily, we have